Hi, my name is Dylan Crimes. I'm here at the School of Health Information Science, University of Victoria. It's a pleasure to introduce Dr. Parveen Badi and Shiraz Chima at the CanPath National Coordinating Center. Dr. Parveen Badi, Dr. Badi, is a molecular epidemiologist whose internationally recognized research program focuses on using biomarkers to identify and better understand the impacts of environmental and lifestyle factors on cancer risk. Very interesting. A particular area of interest has been the role of circadian disruption in cancer risk. Dr. Badi's research has provided valuable insights into mechanisms by which night shift work and sleep disruption contribute to cancer risk. Also very interesting. Given his extensive expertise and experience, Dr. Badi has been invited to sit on multiple working groups for the International Agency for Research on Cancer. Parveen also sits on the advisory board for CHIR's Institute of Cancer Research and serves as associate editor for the Journal of Environmental Health Perspectives. As scientific director of the BC Generations Project, BC's largest ever cohort study, Dr. Badi has been working to expand this unique and valuable research platform with additional data and biospecimens so that it can continue to support innovative population health research. Again, pleasure to introduce Dr. Badi. Shiraz Chimi, I apologize. Mr. Chimi is the data manager at CanPath National Coordinating Center, which I'm assuming is in Toronto, but please correct me. He supports data requests from national and international researchers. Shiraz is responsible for managing CanPath's research data, including generating data sets for approved projects, maintaining auditing programs for quality assurance purposes, and providing consultative advice on data requirements. Shiraz completed his graduate studies at the University of Toronto and has 10 years of experience of research, specializing in population health, genomics, and biostatistics. To date, he has co-authored 9 peer-reviewed articles and has presented 5 abstracts focusing on novel interventions and technologies in healthcare. Please join me to introduce Dr. Badi and Shiraz for this for their presentation today.
Thank you so much, Dylan. Let me try to share screen here, and I will. Is that showing up properly on your end?
Yep.
Okay, good stuff. Well, good afternoon, everyone. It's really a great pleasure to be able to chat with you today about the Canadian Partnership for Tomorrow's Health, or CanPath. CanPath is a large-scale nationwide cohort study which serves as a unique population health research resource in Canada that is made available to researchers all around the world to answer important scientific questions. So I'm going to provide an overview of the CanPath resource today, and then my colleague Shiraz Chima will describe the process by which that resource can be accessed. Okay, so why are large-scale cohort studies important? Well, these cohorts act as population laboratories, if you will, that are really critical to assessing disease risks. In prospective studies like CanPath, we collect data and then we follow the population over time to see who develops disease and who doesn't. Studies like this are needed to disentangle the complex causal interactions of environment, behavior, and biology on risk of disease. It's only by improving our understanding of disease causation that we can hope to develop strategies for early disease detection, which can improve treatment outcomes or even better identify strategies for disease prevention. So CanPath can be viewed as a single large-scale cohort study, but it is in fact an umbrella that brings together 7 individual cohorts that capture participants from across all 10 provinces. Each cohort is somewhat autonomous in that they have the ability to develop their own resources, pursue their own research activities, and support any research activities they deem fit. But each of the cohorts recognizes the importance of large-scale analyses, so they coordinate most of their data collection activities. And there's been a process of data harmonization on top of that. You can see the number of participants recruited in each cohort. The number for Saskatchewan is small because they're currently in the process of recruitment. You see the BC Generations project on this diagram, of which I am the scientific director, and I'll be sharing some details about BCGP specifically throughout the presentation. So here's the CanPath leadership team. This is meant to demonstrate that each cohort has its own scientific director or co-directors, but we as a group contribute to leadership of CanPath as a whole, which is helmed by Philip Awadala. He's the National Scientific Director and also the Scientific Director of the Ontario Health Study, which is the largest of the CanPath cohorts. John McLaughlin just recently retired as Executive Director of CanPath, and Jennifer Brooks, an epidemiologist at U of T, has taken over that role. So you have these individual cohorts, but by combining data from across all of them, CanPath becomes Canada's largest population health research platform, capturing data for over 330,000 Canadians. The data resources that CanPath makes available to researchers are summarized on the diagram here. Keep in mind that CanPath cohorts have the ability to go back to participants to collect new data as part of what we call ancillary studies. And these activities can be initiated by outside investigators. But for the purpose of this presentation, I'm just going to focus on our current resources. While baseline questionnaire data are available for virtually all participants, and biological samples, including serum, plasma, and urine, are available for a majority of CanPath participants, some of the other resources are only available for smaller subsets. So this may be a small fraction of participants across each of the individual cohorts, or maybe a large number of participants from one or two of the cohorts. These types of details can be gleaned via the CanPath website. So with the baseline questionnaire, like I said, this was completed by virtually all participants when they joined the various cohorts. Each cohort used essentially the same questionnaire with maybe some minor variation, capturing data on various demographic factors, health status, medical history, so personal medical history, currently prescribed medications that they were on, detailed family health history, various self-reported anthropometric measurements, their current working status, as well as some employment history with questions like, what was your longest held job and so on, household income, and then various health behaviors, things like sleep, alcohol consumption, and tobacco use. There's also some collection of physical activity data, as well as some very minor sort of basic collection of dietary data. Now, a fraction of the participants in the various cohorts did come into assessment centers at baseline to have various physical measurements performed. So there were some that underwent cognitive testing for things like reaction time and memory, some that came in for more objective assessments of anthropometric measures, where staff members would measure height, weight, hip and waist circumference. There was bioimpedance analysis too, to look at body composition, grip strength measurements, bone density, spirometry used to measure lung function, some assessments of blood pressure, and then various other factors to basically get an assessment of arterial stiffness. And then some underwent a partial resting electrocardiogram as well. Now, being able to link with other data resources is critical for maximizing the utility of cohort studies. There are linkable databases to examine environmental exposures and built environment factors, for example. In Canada, we have the Canadian Urban Environmental Health Research Consortium, or CANU, that has generated spatially resolved data on a number of different environmental exposures and built environment factors that can be linked to participant residential addresses at the postal code level. So here's an example of a study in BCGP that we published using CANU data. We conducted logistic regression analyses where the outcome was the odds of getting less than 7 hours of sleep per night, which we consider to be an insufficient amount of sleep. And this was self-reported on the baseline questionnaire. And what you're seeing here are odds ratios for each interquartile range increase in exposure, along with 95% confidence intervals. And you see here evidence that greater levels of green space are associated with lower odds of insufficient sleep, whereas higher levels of light at night, sulfur dioxide air pollution, and living within 100 meters of a main roadway are associated with greater odds of insufficient sleep. What was really interesting is that the results were largely unchanged when examining each exposure by itself versus considering all of the exposures together in the same model, meaning that each of the factors seems to have an independent impact on sleep. In the newest iteration of the CANU data, which we just recently received, they have included noise data, which are obviously pretty relevant to the question of sleep, and that's something that we'll be taking a close look at shortly. Here's an example of another project that links to built environment data. One of the limitations of the light at night data provided by CANU is that it's based on satellite images that really only capture measures of light intensity. We know, however, that one of the major mechanisms by which light at night impacts health is through disruption of melatonin secretion. And melatonin disruption is also dependent on the wavelength of light. So not just intensity, but wavelength, with bluer wavelengths being particularly disruptive. So we collaborated with an astrophysicist based out of Sherbrooke University, who uses high-resolution color photos of cities captured by the International Space Station to come up with wavelength-resolved exposure estimates that we can then assign to residential addresses for our participants. And so as an example, here's a picture of the Greater Victoria area that was captured from the International Space Station. We've generated these data for Vancouver and Victoria, as well as Calgary and Edmonton, which have been linked to our sister cohort in Alberta. We're now in the process of pooling the data for the two cohorts and are beginning analyses to evaluate associations with breast, prostate, and colorectal cancer risk. Now, beyond environmental data, administrative health data, such as vital statistics and cancer registries, are key to conducting objective analyses of mortality and cancer incidence. Other administrative data sets, such as hospital records and primary care data, can be used to ascertain diagnoses of non-cancer chronic diseases. In fact, the BC Ministry of Health has generated something called the Chronic Disease Registry, which applies algorithms to Ministry of Health data to ascertain diagnoses for a number of different non-cancer chronic diseases. This is a pretty exciting resource because for studies of incidence of non-cancer chronic disease in cohorts such as ours, we've typically had to rely on self-report through follow-up questionnaires, which is a resource-intensive process that's subject to various biases. So as part of a pilot project, we were able to link self-reported chronic disease data from BCGP to the chronic disease registry. And so this table comes from a paper we published last year. It lists self-reported chronic diseases in BCGP that were also captured by the chronic disease registry. Now, the prevalence of disease is generally similar from both of those sources. Based on Cohen's kappa statistic, we see no close to perfect levels of agreement, though there is what we might call substantial agreement between the data sources for things like diabetes, hypertension, multiple sclerosis, and myocardial infarction. The chronic disease registry is not perfect. It's based on algorithms but given its more objective nature, it's very likely to be less subject to biases than self-report. So we treated the chronic disease registry as the gold standard and assessed sensitivity, specificity, and positive predictive value of self-report. And based on that, we concluded that for some chronic diseases, self-report might be okay, but for most, we really need objective sources of information like the chronic disease registry. Now, one of the challenges with CanPath is that administrative health data linkages cannot be completed at the national level. These need to be done regionally by each of the cohorts. This is, in fact, one of the major reasons that a federated model was used to establish CanPath. It mirrors the fact that healthcare is administered at the provincial level without any well-established means to share data across provinces. And this is where CanPath has really been a bit of a driving force to help set up systems with which to share data. For example, the scientific director of the Atlantic cohort, Robin Urquhart, received a grant from the Canadian Cancer Society to establish a means to hold cancer registry data nationally for the CanPath cohort. And this has had some success. There's at least a few of the provinces, including BC, that seem to be on board. Now, in BC, as an offshoot of our linkage with the BC Cancer Registry, we recently established something called the Virtual Tumor Repository. By allowing us to characterize cancers at the molecular level, tumor samples can support not only detailed clinical research into indicators of prognosis and treatment response, but epidemiologic research into etiology, prevention, and early detection. Population-based cohorts like the BC Generations Project are an ideal resource for tumor specimens since they are annotated with detailed demographic, lifestyle, and health history data that would support innovative cancer research. So we didn't have the resources to establish a physical tumor repository, but given that pathology departments across the various health authorities in BC, most of which are depicted in this map, are required to store samples for 20 years after pathology reviews are completed, we established a process that can facilitate access to tumor samples that were collected for pathology review from BCGP participants. This involves a number of steps, including review of pathology reports, applications to laboratory services in each of the health authorities, and there are costs associated with these requests as well. Of all solid cancers that were diagnosed in BCGP up to 2020, we successfully identified 93% of the pathology reports for those cancers. We then attempted to retrieve a random set of 200 tumor samples, of which we successfully obtained 92%. So overall, our retrieval rate was 86%, which is higher than many other cohorts around the world that have established tumor tissue resources. And all of this is described in a paper that we published last year. I have a master's student that is using this resource for her thesis. It's a pilot study where she will determine if lifestyle factors captured before cancer diagnosis, things like diet, exercise, smoking, and alcohol consumption, are associated with levels of SPARC, which is a protein whose expression in tumors has been associated with cancer prognosis. The hypothesis being that cases engaged in healthier behaviors before their cancer diagnosis will have tumors that express higher levels of SPARC and thereby have better outcomes. So this is a study that could only be done with a resource like BCGP, where you have lifestyle data collected before disease diagnosis. So we brought tumor samples in for 50 colorectal cancer cases and then shipped them to the Dealey Research Center in Victoria, where our colleagues took cores from the samples and created microarrays like the one shown in the picture here. They then made slides from the microarrays, stained them with SPARC antibodies, and using an automated system, scored the number of cells expressing SPARC, as well as measuring the intensity of the staining. We recently received the data and are in the process of doing the analyses. Of the CanPath cohorts, only BCGP has established something like this so far, though it's not a service that we have yet been able to offer broadly, given how intensive the retrieval process is. But there is interest among the other cohorts in establishing something similar, given the high research value of this type of resource. So this slide is just meant to illustrate that the value of CanPath has grown over time and will continue to do so as we collect more data and we ascertain additional health outcomes. To date, we have and are supporting over 270 projects with over 280 publications so far. I also wanted to briefly mention that given the scale and scope of CanPath, it has been recognized as a large-scale precision health initiative that has been invited for inclusion in various international efforts, such as the International 100,000 Cohort Consortium, which includes some impressive cohort studies like the UK Biobank. There are certain health outcomes, rare cancers, for instance, that no individual cohort has the power to investigate. So bringing together these various country-specific endeavors is really a great opportunity to shed some light on the etiology of rare health conditions. And then I just wanted to finish off by directing you to the BCGP website here. Through the researcher tab, you can get detailed information about our data and biospecimen holdings, about the process by which you can access these resources to support your research, including the ability to go back to our participants for ancillary studies involving collection of new information or biospecimens. But as part of his presentation, Shiraz is going to be discussing the CanPath access process through which BCGP resources can be accessed as well. Thanks so much for your attention, and I'll turn it over to Shiraz.
Thank you, Parveen. I hope you guys can hear me okay. Yes, I'm just, okay,
Yes.
Perfect. Okay, great. Thank you so much. I'm just gonna do the screen share right now. Are you able to see the slides here?
Yes, they're not on. They're not in presentation mode. Yes.
Oh, sorry. I think I have it the other way.
Shiraz, would you like me to share your slides from my system? Would that be useful? Oh, there we go.
Sorry, I was on mute there. Was that Joanne? Were you?
It was Leah. I can share
Oh.
them from my system if that's useful for you.
Sure, if that's okay. I was just about to do it. Could I give it another go?
Of course, absolutely.
Okay. Sorry about that.
No, not at all. Not at all.
No, I have two screens here, so I'm just trying to navigate them.
For sure.
But I'm gonna try to do the screen share one more time. Is it still showing up as presenter mode? Okay, I think I may have to just switch it to. It's okay. If it's okay, could you pull up my slides for me? I'm sorry for.
No, not at all. Not at all. Here we go.
Okay, great. I'll just minimize it here.
And I can give you remote control version as well, so you can just go ahead with your own mouse and move them as you wish.
Oh, okay. Let's see if I can.
at the bottom of the screen, there's the light colored arrows, if you like, when you move your mouse.
I'm not able to see them, but
Yep, they're moving.
oh, that was me. Okay,
That was you.
that was me. Okay, great.
That was you.
I'm just gonna can't really see how I'm going backwards or forwards. Oh, okay, I see it now. Thank you so much. Okay,
You're very
this should
welcome.
be great. Excellent. Sorry everyone for the technical difficulties. I'll just put this aside here. I have a few notes I just wanted to pull up as I. There we go. Okay, great. I'm gonna just have this rolling here. Perfect. Okay. Great. Thank you so much, Dr. Bhatti Parveen, for the overview of CanPath. And just to reintroduce myself, I'm Shiraz Chima, the National Data Manager at CanPath and at the National Coordinating Center, which is located in Ontario, Toronto. So I'll just be giving a quick overview of how the CanPath platform is able to provide researchers with access to large amounts of population health data and biospecimens as well, collected across Canada from participants across Canada. So one of the common challenges, as Dr. Praveen Bhatti mentioned, is, in health research, we're often dealing with dispersed data sets and the time and effort that's needed to harmonize that data in order to be able to conduct individual level or pooled analysis. And this is where CanPath really comes in. The National Coordinating Center hosts the harmonized data sets for 7 regions across 10 provinces in Canada, allowing for a centralized access process. All this can be done through the online portal, which you're seeing here on the screen, where researchers can explore and identify all the epidemiological and biological data available from all the participating cohorts. And access to this CanPath data platform is available to researchers both nationally and internationally, including trainees from recognized institutions. The portal allows researchers to explore the harmonized data set, which we call here the core data. This is available from all the regions. It has nearly 4,000 data points, which includes health, medical, lifestyle, and even the COVID-19 serology study data. In addition to the core data, we have merged comprehensive environmental exposures that Praveen had mentioned through our partnership with Canoe. And additional to that, you'll see on portal the ability to explore subtype studies. So subset studies we've done include genotype data for nearly 5,000 participants. And in partnership with the Canadian Alliance for Healthy Hearts and Minds, we have EMR-based research data, which includes imaging and cognitive assessments for more than 7,000 participants. And more research data continues to come in, and you can see them getting updated on our portal system. For instance, just a few months ago, we added onto our core or harmonized data set the follow-up or the second time point for our COVID-19 antibody study, which includes questionnaire data related to COVID symptoms, vaccinations, hospitalizations, as well as serology test results. And we hope to continue growing this platform and adding more follow-ups and linking more data sets in years to come. Oh, there we go. The portal also, oh, sorry, I think I skipped a slide there. There we go. Okay, sorry. So yes, the portal also keeps updating and tracking any existing and new biosamples collected through the regional partners as well, providing numbers and details to researchers who are looking to prepare their projects and request for access. This is a great advantage to researchers interested in conducting large and pan-Canadian studies, because they're able to query and apply for both the data and the biosamples through a centralized platform. in this slide right here, we're just illustrating what we have from from all the regions, and that's more than 145 participants with blood. We also have urine samples from more than 90,000 participants, and interestingly, toenail clippings from more than 30,000 individuals coming from Atlantic Path. So this is just an example. If somebody was to be interested in toenail clippings, they can come to the National Coordinating Center, and we would be more than happy to facilitate getting different types of biosamples, different variations of data, and getting that data access in a one-stop shop. So once researchers have the ability to explore and go onto our online portal and see the data and the biosample information available, they can go ahead and register and create an account, which allows them to download certain variables and information and save a list of variables that they're interested in for a particular project. And they can also request queries for more detailed aggregated tables, such as linking biosamples to any specific conditions or diagnoses that they're interested in. And this screenshot just shows where they would go ahead. I've highlighted it in red where they can log in, and there's a small tutorial too that we provide on how to navigate the online portal system. And sorry, I'm just waiting for the screen to move. There we are. Oh, sorry. Here's a quick screenshot. I'm sorry for the small font here, but here's a screenshot of what researchers would see once they proceed to the application requesting for access. And this is just a conventional agreement or a form that requires information about their institution and just to check if they meet the requirements and their projects are suitable for CanPath's vision. This is just something to see what to expect. Now, once researchers submit a request to the National Coordinating Center, a process is initiated which follows 3 steps. The first being an administrative review, which confirms the proper credentials and requirements in order to conduct the research. Secondly, a feasibility review, which assesses the scientific rigor of the proposed project. And lastly, a review by a delegated committee, which is done on a rolling basis. Now, the full access review process can take several weeks. The access requests that are limited to just the harmonized or core data, which includes the COVID-19 data sets as well, they would be eligible for an expedited review, which would limit the review to just at the feasibility level to 1 scientific director and to 1 member of the access committee. But all other requests that include and are not limited to biosamples or any administrative linkages would go through the full access process, review process that's illustrated here. Sorry, so now I'll be providing an overview of a unique resource available through CanPath, known as the student data set, which provides an opportunity for trainees to get hands-on experience working with real-world population health data. As Dr. Bhatti mentioned, CanPath is one of the largest population health research platforms in Canada, focusing on a range of chronic diseases in adults. The amount of data collected is a key strength for this platform, which allows linking of many behavioral, environmental, and biological information to investigate disease cause and determinants. Since its inception, the platform has gained lots and lots of interest in the research community, so much so that researchers and faculty members have requested using it in a teaching environment. So as you can imagine, there's certain guidelines for getting access to this data. So the challenge became, how do we provide students and trainees in a course or a program with access to this real level world data to, train on it and to learn from it? And this is where we came up with a solution known as the student data set. By developing a student data set, we've added an element to enable the use of a sample of the data in a teaching environment. This is a synthetic data set that's been generated using a subset of the overall cohort. And we created it using an R package known as synthpop. This package essentially replaces and rearranges sensitive records with simulated values derived from probability distributions and key features of the real-world data sets. The data set provides students with hands-on experience to population health data while ensuring the privacy and confidentiality of the study participants. Sorry, I'm just going too far ahead. There you go. Sorry. Now, we used data from 5 of the founding regional cohorts to develop the student data set. They span 8 provinces. And you'll see here, it includes the BC Generations Project, Alberta, Ontario, Quebec, and the Atlantic Path regions too. As other cohorts complete their baseline data collection, we're hoping to eventually include them as well in future iterations of the student data set. Just to summarize what to expect, should you be interested in using the student data set, you'll find a sample size of nearly 50,000 participants and over 350 variables, most of which are categorical, with the exception of age or other measures, which are numerical values. The data is derived from 4 of the same type of data sets you would see on Portal, and they're listed over here. It includes the baseline questionnaire, additional diseases, the COVID-19 follow-up questionnaire, which was done in 2020, as well as the canoe environmental exposures. And I'll go into them a little bit more in the next couple of slides, just to give you a taste of what you could expect. There you go. So from the baseline questionnaires, you will find data related to demographics, health status, medical conditions and diseases, but as well as behaviors, lifestyle behaviors such as sleep, substance use, nutrition, physical activity, even their work status. And most recently, we even added a couple of variables related to COVID diagnosis and test results. You'll note that these variables will follow the same convention as the actual core or harmonized data set that you'll find on and be able to explore on Portal. So based on this information, you can see their prefix, so sociodemographic being SDC, sleep being SLE. These are just characteristics that we've given to the variables and mimicked the actual real world data set so that students can get an idea of how to work with it, how to analyze them. Now, this is an interesting one. Additionally, we've included detailed variables on medical conditions from 3 of those regional cohorts, which includes BC, Ontario, and Quebec. They had the largest amount of data, so we've included their additional disease questionnaire information into the student data set. These variables always begin with a DIS and end with letters ever or age, and provide detailed breakdown of the type of medical condition and the age of onset. So on the screen, you'll see an example of diabetic retinopathy, and just the breakdown of how we categorize them and the naming convention for those, making it easier for analysis purposes again. And this also allows for some causal and temporal analysis too, looking at if they had a condition and at what age, at the age of onset that they had the condition occur. So finally, the last source of information comes from the federally funded canoe dataset, which Praveen had mentioned, which is an area level environmental data, which has been linked to using postal codes to CanPath participants. This type of data includes neighborhood density, green space, air quality, and how conducive the environment is to active living. So it can make for some very interesting analyses then. Now, a good way of showing how this applies and could be used. Oh, sorry, I think I may have. Oh, yes, I did. I went too far ahead. Go back. Yes. Sorry. That's the one I wanted. Sorry. Now, among many advantages of the student data set, along with being a large sample, real-world data, is that it comes at no cost to faculty members. So really, the ability to use it and get training from the real-world data at no cost is quite a good, I think, as we all know in the research community, is quite a good advantage. So just highlighting that again, one of the key advantages of using the synthetic data set at first. Now, yes, this is the one. So just to give a recent example of how the student data set has been used, I've taken a soundbite or a quote from Professor Kwan Liu at the University of Toronto, who used this data set for her data challenge as part of the AI for PH, which stands for Artificial Intelligence for Public Health, a training program recently, just this last summer in Toronto. Not only was it well received by the trainees and mentors, but there was some unique data exploration. For instance, you'll see some of the examples mentioned here. Association between depression and cardiovascular disease, relationship between walkable neighborhoods and physical activity. And my favorite is risk of developing type 2 diabetes compared in white versus black adults. So a little bit of social determinants equity analysis using causal inference. So just an illustration of how the student data set can really facilitate training and bring about some interesting findings. Right, so, oh, sorry, I think I jumped ahead again. There you go, okay. Requesting access to the student data set is quite simple as well. All you need to do is meet the requirements that are outlined here. And you can also find these on the CanPath general website. Generally, the requesters must be instructors in a recognized academic institution, and they must be requesting it for the purposes of a course or a teaching session. Requesters can just simply fill out a form that's available online and send it to our general access office email address. And the requests are then reviewed by NCC and our leadership team at the National Coordinating Center. So there's a faster turnaround than just the regular access application process. There we go. Now, an important point I should mention is since the student data set is for training purposes only, any findings that come out are not allowed to be published. However, if you do come across a finding that's of interest or would like to replicate or publish using the CanPath data, we welcome anyone to apply for the full CanPath data set, which would give you more than 300,000 participants and allow for a more powerful analysis too. And we do provide a discounted rates for trainees and our early faculty members as well. So that's another advantage. Back. There we go. Okay, perfect. Now I'm just wrapping up. So before I wrap, I would like to just thank again all the participants across Canada that took part in CanPath and generously contributed to their time and their data and their biosamples for the purposes of research and knowledge advancement. Without them, we wouldn't be successful and be able to achieve the amount of research that we have so far. So thank you again to all the participants. And as well, yes, and of course, I'd like to also give a big thank you to our regional partners, including the BC Generations Project, and thanks to our host institutions at the universities and as well as our sponsors for the CanPath program. And I think with that, I'll wrap it up. I think my last slide just got skipped there, but thank you so much